Hello, my name is Natalie May, and this is everything you need to know about making feedback more than just noise. Before we get into it, first of all, I need to introduce you to Aidan.
Hi, you've called the clinical advice line. This is Aidan speaking. Hey Tim, how are you? Yep, okay, wonderful. From Melbourne Division, great. And you've got a 42-year-old male with chest pain. Okay, right. So Tim, can you just give me the vital signs? Yeah, we'll come back to that first. I just want to get a sense of how sick this guy is. So the heart rate's 98. Okay, and the blood pressure? 140 on 80. Okay, good. And how about his breathing? You haven't done it yet. Yeah, no, mate, that's okay. And how about his SATs? You haven't thought to put them. Yeah, mate, that's okay. You're just a first responder. That's all right. Why don't you pop on the SATs for me and let me know? Yeah, great, awesome. Okay, so now you said chest pain. Is that radiating anywhere? Yeah, okay, and how bad's that chest pain? Okay, it's about an 8 out of 10. Wow, all right. Okay, so have you called an ambulance? Yeah, they're on their way. Okay, excellent. Good. Where's the patient at the moment? You've got him sitting down on a chair. Okay, excellent. Right, now with this pain, what have you done for it so far? You're not sure, that's why you called me? Yeah, awesome. Well, I'm really glad you called me, mate. That's great. I'll help you out. So let's just go kind of head to toe. Looking at the patient's face, does he look pale? Oh, he looks flushed and red. Okay, right. And okay, you've taken the shirt off because of the chest pain. Yeah, no, sure, that's good. And it's really hurting on the one side. Okay, which side's that? On the left side. Yeah, right. Okay. Right, sorry, especially where the bruising. Sorry, mate. Just rewind for a second. Bruising? Yeah. Horse. Right. Okay. Sorry, Tim. Can you just start from the beginning there? So what's happened today? Right. Okay. So this gentleman has been right. So he's pushed between the horse and the barricade. Okay. Right. And he felt a crunching in one of his ribs. Okay.
So, why is feedback important? Well, feedback is part of our everyday lives, whether we like it or not. And unfortunately, sometimes it doesn't go quite as well as we would like it to. It's an important part of our clinical careers, both receiving as a trainee and giving when we become more senior and supervise trainees. But again, it's something that people often feel very strongly about because it's not always handled very well. If you think about yourself as a driver, assuming that you know how to drive, would you consider yourself to be better than the average person you meet on the road? I suspect you probably would. Most people, when asked, think that they're better than average at driving. And that's despite the fact that when we are driving, we often receive lots of informal feedback from other drivers that might suggest an alternative reality. But what David Dunning and Justin Kruger tell us in their Ig Nobel Prize winning piece of work was that it doesn't really matter whether we are in the bottom of the pile or right at the top of the class. We're not actually very good at knowing how good or bad we are at things. So think now about the kind of feedback that you give other drivers. Are you somebody who doesn't hold back? Do you give feedback that is in the interest of the person receiving it? You probably don't. So we're going to talk through some strategies, all the things that I think about when I think about feedback, and hopefully get a bit better at it. Because this stuff is really, really important. It's something that people often feel very, very strongly about. And usually people remember the times that they've received feedback and it really wasn't handled very well. And that can be incredibly harmful to our learners. So over the next 15 to 20 minutes or so, we're going to talk about all the aspects of feedback and try to navigate a path to being better at it. But a little warning, not everything you see will be a how-to. Some of it might well be a how not to. I've got some resources for you which will be mentioned throughout the presentation. So if you want to read more, there is one paper, one actual book and one blog post that will build on some of these ideas. And you can find each of those with that little web link at the beginning, bit.ly/one paper, one actual book, one blog post. And we'll come to where they're relevant in a moment. So in that simulation we just watched right at the beginning, we saw Aidan, who is a qualified doctor now and a qualified paramedic, who works in a voluntary capacity for St John Ambulance as a clinical advice line attendee. And we saw him becoming fixated on ACS, acute coronary syndrome, as a potential cause for a patient's chest pain. And he went some way down that path in providing clinical advice before he realised that actually the patient had traumatic injury. So if we imagine that this has happened and Aidan has come to us and asked for some feedback on his performance as a clinical advisor, we're going to use that as a framework moving forward. So the fact that Aidan's come to ask for feedback is really important. In one of the most seminal papers about feedback in clinical education, Jack Ender said that there were some really helpful stipulations for what feedback should look like. And the first is that it should be expected. So the fact that Aidan has asked for it is really, really helpful. You can find Jack Ender's paper here. It's called Feedback in Clinical Medical Education. It's from 1983, so it's more than 40 years old now. If a QR code is easier, you'll find it here. So before we launch into this feedback that Aidan has asked for, we need to ask ourselves 4 questions. Is this necessary? Is it the right time? Is it the right place? And am I in the right frame of mind? Because feedback, whether we like it or not, is about the receiver, not about the giver. And that is so important. I'm going to say it again. It's about the person receiving the feedback. It's not about us as the person giving the feedback. So let's go into those 4 questions a little bit. Is it necessary? We need to make sure that this is something that we actually need to give feedback about. We all have things that wind us up, some things that seem to immediately enrage us. Maybe it's just me, but there are some people who just annoy me and every single thing that they do is infuriating. So we need to make sure what we're going to give feedback about is actually something that matters in the grand scheme of things. And this is featured in Jack Ender's paper too. He said not only should it be expected, but it should be specific. It should be limited to behaviours that can actually be modified by the learner, things they can do something about, not their way that they look or who they are as a person. And it should be first-hand data, so it should be our own observations wherever possible, not information that's been processed through another party. In this case, we can see that there is actually something for Aidan to learn from this clinical encounter. There's something to learn about the loss of situational awareness and the lack of that overall picture. And so we can tick that box. Yes, this is going to be specific. We've got something to change and we have observed this for ourselves. Next, is it the right time? So we know what this means in our clinical practice. We know we shouldn't be giving feedback on someone's performance immediately after a patient has died. We shouldn't do it at the start of a night shift when we then expect the person to work for 10 to 12 hours afterwards, where they're going to be ruminating on all the things that we've just said. We shouldn't do it just before they go home or go off on holiday, where they're going to take it with them and have no opportunity to reflect and come back and have ongoing conversation. Arguably, the best time is during a regular planned meeting at which feedback is expected to occur. So these kind of regular check-ins we have as supervisors with our trainees. And if we don't have those, we need to be asking ourselves, why not? Again, Jack Ender talked about this. He said that feedback should be well-timed. The third question is the right place, and we know what this means too. We don't give feedback in front of our colleagues or in front of patients. We don't do it in the corridor of the hospital. We need to do it in the right environment where we're relaxed and we can be curious. We're not going to be rushed. We're not going to be interrupted. And the fourth question is, am I in the right frame of mind? Am I in the right place to give feedback to a learner such that I can focus on them and what they need? Or am I hungry, angry, late, tired, stressed? Did somebody just scream at me for something that was outside of my control? If we are caring for ourselves well, then we are better able to care for others. And that's really important when this is such a vulnerable time. So the answer to all those 4 questions is yes. Aidan's waiting in my office, so I'm going to go in and give him some feedback.
So, Aidan, hi. Thanks for coming to talk about that call that you took as a clinical advisor. How are you feeling?
Well, I launched in pretty quickly to the ACS pathway, and yeah, I mean, it ended up being trauma, but I think I was pretty supportive. You know, I'm pretty happy with how I was. Yeah, it's just like, I don't know. I think I could probably do better. I was maybe a bit controlling.
I think you're great. Everyone really likes you. Everyone loves working with you. You're really friendly. You've got a great manner. You're a great member of the team. So thanks.
Oh, thanks.
Okay, that didn't really feel quite right to me. So let's find out why not. And let's ask Aidan. Aidan, how are you feeling about that exchange?
I'm a bit frustrated actually. I was hoping for some guidance on how to improve, but I didn't really get that. Don't get me wrong, Nat said some really nice things, but I just don't feel like I've got any idea how I can get better at being a clinical advisor.
And this is something we come up against all the time. So if you're going to read one book about feedback, I would highly recommend reading Thanks for the Feedback, The Science and Art of Receiving Feedback Well by Douglas Stone and Sheila Heen. And you can find that at this short link, or you can use this QR code. And in this book, the authors talk about the fact that there are 3 different types of feedback. And this is a challenge we come up against. If we don't understand this, what happens is we give one kind of feedback while the learner is expecting another, and that disconnect can provoke all those emotional responses that we were thinking about earlier on. So the 3 types of feedback are appreciation, coaching, and evaluation. We do need all 3. So if we think about our improvement, our journey to improvement as being our way to driving to a better destination, we need fuel, we need to know where we're going, and we need to know how we're going to get there. So appreciation is something that really gives us motivation. Quality appreciation is specific. It's in a form that the receiver values and hears, and that it's authentic. It's actually really hard, but it's incredibly powerful when we get it right. And this is a fuel that kind of keeps us going on our learning journey. Coaching gives us direction and helps us to grow. So this is giving us the directions as we're driving of where we need to go to. So coaching is sparked by a need to improve or to meet new challenges or a particular problem where the giver of the coaching feedback wants to create change. And this is really what Aidan is looking for here. And the third type is the evaluation, which is really like the destination, a measure of whether we are there yet or not. It's naturally comparative, and we can make it a mix of objective and subjective if we also include emotional components, so how things felt to us. But you can see that if someone is just looking for appreciation, but we give them evaluation, that's going to create an immediate disconnect. And the way that we often explore this in medical education courses is using the hot and cold game that in the UK is called Hunt the Thimble, essentially a game where someone is looking for a hidden object, and what they want in order to be able to find it is coaching. They want gentle adjustments of their path and their journey to get them to what they want to achieve. So when we do this in separate rounds, and we play with the feedback. We have the givers giving non-specific but very effusively positive appreciation. We give specific but negative evaluation. You're not very good at this, you haven't done that yet. And we give emotionally neutral coaching. And what's really interesting is that the positive appreciation, while you would think, might make you feel really good, that's actually quite frustrating to learners when what they want is coaching, even if you're saying really nice things. Obviously, the negativity has a really deeply profound effect. But that emotionally neutral but task-specific coaching is often interpreted as being positive because it's giving the learner what they need in order to find the thing that's missing or to complete their task. And if we want to take it an extra level, we also do a round where we give no feedback whatsoever. Everybody just sits in silence, because that represents something that we often find in education circles as well, that people are looking for feedback and they just don't get it. Again, an extremely powerful experience. So let's try speaking to Aidan again, but this time we're going to use the classic Pendleton's rules, which we'll talk about in a moment.
Hi Aidan, thanks for coming to talk about that interaction as a clinical advisor. How are you feeling?
Yeah, look, I think I was probably a bit too quick down the ACS pathway. I'm pretty happy overall, but I think there's a few things I can probably improve on, yeah.
I think it was really good that you went with the observations first. I think that was a really good thing to do. I think you're right, you went too far down the ACS pathway. You pretty much missed the idea that there was going to be a pneumothorax, and that was pretty dangerous, really. But you were very nice to him at the end, and you definitely directed him back onto the right track, so well done.
Thanks.
So once again, that didn't feel quite right. Let's ask Aidan, how are you feeling now after that feedback interaction?
I feel pretty awful. I've been beating myself up for cutting the first responder off and going down the ACS pathway. And Nat's confirmed to me that she thinks I'm dangerous because I missed the possibility of a pneumothorax.
Well, that's not all that happened. I said some really nice, what did I say at the beginning about how good your performance was?
I think she said...
And this is the challenge of Pendleton's rules, also known as the shit sandwich, the idea that you can give the coaching sandwiched in between some appreciation at either side. this positive, negative, positive structure. And that positivity is lost, particularly when learners have received feedback in this format before, because they just completely discount it and they look for the sandwich filling. The positivity is lost no matter how good and how important it is, because we're going to focus naturally on the bad part. And actually, that's not even what Pendleton said when the rules were kind of evolving. But what we tend to focus on now is the learning conversation. So this is a technique based on conversation theory, the idea that we can promote and support greater self-awareness through critical inquiry, much like we do in simulation debrief. So we're going to use open-ended questions and explore the responses to the situation, followed by advocacy with inquiry, stating what we've seen and observed and asking the person involved for more information on what happened during that scenario. And again, 40 years ago, Jack Ender was talking about this. Subjective observations are labelled as such, things that we have seen and understood for ourselves and what we are thinking, and then focusing on decisions and actions. Why was that decision made? Why did you decide to do what you decided to do? So let's have a go at speaking to Aidan in the format of a learning conversation instead.
Thanks for coming in to talk about your experience as a clinical advisor. How are you feeling?
Yeah, no, thanks. Good. I feel like I can improve. I think I went down the ACS pathway a bit too quickly, maybe. Yeah, I just feel like I can improve.
It looked to me as though you thought that Tim was a little bit out of his depth. Is that fair?
Yeah, no, he sounded a bit panicked on the phone, and I guess I just wanted to kind of calm him and reassure him, but I just didn't feel like he was getting anywhere, so I kind of wanted to take control and take him down, and I heard chest pain, and I thought, all right, well, we need to start, I need information from you. So I kind of tried to take control and grab the information from him. But yeah, I guess it didn't really work out as well as I wanted.
I think that's a real challenge for somebody in your position, taking these kind of phone calls. How do you balance that need to shape somebody's actions and get the information you want with letting them tell the story that you want? Have you had any thoughts about how you might approach that differently?
Yeah, I think probably could have just given him a bit more time in the beginning to let him get his story out, and then maybe use something like I missed and kind of said, can you give it to me in an I missed Amber way, and then just stopped and let him talk a bit, and that way I would have actually saved time and he could have just gone through what he had to get out, and then I'd be able to kind of understand where he's coming from and help him out.
I don't think it was wrong at all to get those obs and get that oversight about knowing that the patient was stable in the first place. But I think you're right, using that structure then to kind of sit back a little bit, take a pause point, and then get that full sum of the situation would have been really helpful. I'm really interested to know how that turns out for you.
Thank you so much.
So let's ask Aidan how he felt after that feedback interaction.
That was really useful. I've been beating myself up for cutting the first responder off and going down the ACS pathway, and worrying that everyone thinks I'm useless. But Nat helped me see that it's a communication skill that I can develop. I've got some useful ways of doing things differently next time too.
So what does this mean for us as educators and as learners? Well, the primary message is that we need to align our objectives. We have to understand what the learner wants from the conversation, and then as an educator, we can explain the different types of feedback and focus on the type that they want, and then explore a topic in collaboration. What about though when it's something non-clinical, when it's a behavioural or a personal thing, when we don't want them to discuss necessarily, but there's something we have to feedback about that must change? These are often the hardest moments to manage in the feedback setting and the ones that we most want to run away from. If we think back to that sim right at the beginning, I don't know if you noticed the comment about Tim being just a first responder. If we imagine...
So the heart rate's 98, okay, and the blood pressure? 140 on 80, okay, good. And how about his breathing? You haven't done it yet. Yeah, no, mate, that's okay. And how about his SATs? You haven't thought to put them. Yeah, mate, that's okay. You're just a first responder. That's all right.
So if we imagine that Tim has come to tell us that he's actually heard comments like this about being just a first responder from Aidan in the past, and he's found it quite disrespectful, that it's actually damaging their working relationship, then obviously that's something we need to feedback to Aidan. But how do we provide that feedback? Well, it can really help to handle these situations as if it's conflict resolution. So the skill I use and teach is giraffe language, which is developed in the Centre for Nonviolent Communication. If we think about the animals on the African savannah, the giraffe language is different from snake language. Snakes are low to the ground. Everything they see is a threat. They bite first and ask questions later, and their language often starts with the word you. You've done this, you've said this, you did this, it's your fault. Giraffes, by comparison, have the biggest heart of all land mammals and these long necks that give them a great overview of the whole situation. They speak from the heart, they've got a big heart to pump blood all the way up that long neck, and they use phrases that start with I, recognizing that actually the only thing that we ever really understand is our own perspective on a situation. So giraffe conversations follow a structured approach where we agree the facts, verbalize the emotions, explain the need, and outline an associated task. So if we agree the facts in this case, that's really important. It's best if the person that you're speaking to will agree what's happened, but that can cause you to fall at the first hurdle. It doesn't have to be, can we agree that you said this thing? It can be, can we agree that somebody was upset by the conversation, however you meant it to be interpreted? Can we agree that you made a comment that may have been misconstrued or misunderstood? Because once we've agreed that that event has happened, we can go on to verbalizing rather than expressing the emotion that's associated. This makes it a lot easier for people to deal with. People often don't respond well to having a wall of emotion coming at them, which is why conflicts often fall down. But if we can put words around it and say, this has made me concerned, or this has made somebody else upset, then we can talk about things in a way that is less confrontational for the person involved. And then we need to explain why the emotion is arising. So this has made me concerned because I need to know that team members in my department can work together respectfully. Or this has raised some concerns for me because there are rules about workplace behaviour that I need to know that you're aware of. Or because even if it was intended as a joke, it was upsetting to another team member during a high stress situation. And we know that rudeness can affect team performance. So I need to know that the team can perform well under stress. And lastly, we finish up with a task. We make it clear what we want to happen from here. So I'd like you to apologise to Tim and maybe have a think about why you might have responded this way towards him. If there's something at the heart of it, then bring it to me and we'll talk about it together. So let's have a look at how that would look in reality with Aidan using the giraffe language.
Thanks for coming in to talk to me today. And this is a little bit difficult. The call that you had with Tim, do you remember at some point saying to him that he was just a first responder?
Yeah. I think so, yeah. But I mean, I just kind of meant it in passing, like, don't worry, like, yeah. Why?
Unfortunately, Tim's a little bit upset about that comment, and whether or not you intended it to be that way, he feels it was a little bit disrespectful about him and his skill set, and he's quite upset. So he asked me to have a bit of a chat with you.
Yeah. I mean, I didn't mean it in like a disrespectful manner. I just meant like, like, don't worry, I'm here to help you, kind of. Damn.
I understand. And these things do happen. I guess from my point of view, that's going to impact the relationship between you and Tim if he's going to call you again for some advice. And I need to know that that people can call you for advice and not be distracted by the occasional slip of the tongue that's going to impact their ability to do their job, because we know that rudeness in teams affects everybody.
Yeah.
So what I'd really like you to do, I think Tim would appreciate an apology, and I know that that's going to be really difficult, so I'm happy to set up that meeting for you and come and facilitate that, because I know it's hard to sit in front of somebody. And the other thing I'd like you to do is have a little think about where that came from. I know you're saying you didn't intend it to be offensive at all, but sometimes we carry biases that we're not aware of, and I just want you to have a little think about whether there's anything underlying. And then we can meet up next week and have a coffee and a cake and a bit of a chat about that and see if
Yeah, that'd actually be really good. Thank you.
Thanks, Aidan.
So let's ask Aidan how that conversation felt.
Honestly, I'm feeling pretty bad, especially now that I know Tim's upset. But I don't feel like I've been told off. In fact, there's actually a clear plan to put this situation right, and I'm really grateful for it. I didn't mean to upset anyone, but I also feel like Nat understands that this was just an error of judgment on my part, and she's going to help me fix it.
So we're going to park that conversation with Aidan. There's more information about the giraffe rules and feedback at this blog post that you can find over at St Emlyn's, and the QR code is there. So let's park Aidan all the way to one side, and now think about ourselves in the role as learners. because we can't always control the kind of feedback we get. And unfortunately, most of the people who give us feedback aren't here thinking about how to do it better. When it isn't what we want, our tendency is to jump to wrong spotting, which is finding all the things that are wrong with what the person is saying. You have no idea what it's like to do my job, so how can you possibly have anything useful to tell me? And we just chuck the whole thing out the window. So here's an example from my practice. I was working in a small hospital. I saw a child with chickenpox and a fever who was reasonably well but not using their arm to crawl. I x-rayed the wrist and I saw this periosteal reaction. I referred the child for admission for intravenous antibiotics for osteomyelitis, and the next day I'm asked to explain myself because the radiologist in this small hospital says that this kind of injury is classic of non-accidental injury. How could I miss this? Call yourself a paediatric emergency physician. Well, as you might expect, I feel absolutely outraged. I had good reasons to make the decisions I did. I feel misrepresented. I'm indignant. They have no idea. They didn't see this patient. They didn't take the history. And when the images are subsequently discussed with the tertiary paediatric centre and the paediatric radiologist agrees with me that this is likely osteomyelitis, I'm filled with righteous anger. In fact, I'm furious, and I think the person giving me the feedback is an idiot. But what we need to learn in these situations is to practice right spotting. The feedback was handled badly, but there is still something to learn. And I teach people all the time to never ever forget to think about non-accidental injury. And if I'm completely honest, I didn't think about it in this case. So there's a valuable learning point that I still need to take away from this that I could really easily lose in that sea of emotional reaction. This is really hard, but it is valuable. So if we can step away for a period and consciously manage and validate our own emotions so we can pick out what one tiny thing might have been right about the feedback you received, even if the methods were terrible, then we can definitely grow and move on as people. And finally, we've talked a lot about correcting and changing behaviour, but one thing we can absolutely do is give lots more positive feedback. Lots more. We naturally remember the bad stuff, so we probably need to give somewhere between 3 and 10 times as much positive feedback as we give developmental or correcting and changing feedback for it to feel evenly balanced. And we can get really meta about it. We can give positive feedback about giving positive feedback. When we hear other people giving specific positive feedback to someone, we can tell them that is great positive feedback. So please go out there and try to give really good quality positive feedback to people around you. All the things that make good constructive feedback also make really good positive feedback. In summary, feedback is essential for all of us to improve, both as individuals and as teams, and of course our services need it too. So to give better feedback, we need to ask ourselves 4 questions before we start. Is this necessary? Is it the right time? Is it the right place? Am I in the right frame of mind? We need to know what kind of feedback our learner wants. Is it appreciation, coaching, or evaluation? And we need to align ourselves to what they need. We can use learning conversations to help them to solve their own problems. And when we get feedback ourselves in a suboptimal way, we can train ourselves to move from wrong spotting to right spotting. We can use the giraffe language to tackle the tricky stuff in behavioural and personal feedback. And we should be mindful of the balance between positive and negative, striving for at least 3 to 1, but ideally closer to 10 to 1. Here are those 3 resources again, bit.ly it should say, /1 paper, 1 book, or 1 blog post. And lastly, I'll leave you with this thought. Feedback is not something we should be afraid of. It's something we should be better at. It's something to embrace with our arms wide open, exposing our hearts to each other so we can become the best clinicians we can and deliver better care to our patients. Thank you for listening.